Yes. Okay.
So good afternoon, everyone. My name is Dr. Shin. Today I'm going to present my research, the relative occlusal force of distal end implants and adjacent tooth, a cross-sectional study. My advisor, Dr. Pravet Seri Chetapong and Dr. Varirat Jengpapakorn. We are from Aesthetic Restorative and Implant Dentistry program, Faculty of Dentistry, Chulalongkorn University. So for the introductions, I would like to talk about the difference between natural tooth and implants. The natural tooth has the parental ligament in a natural which exhibit a movement when loaded by occlusal force. Moreover, in the PDL space, there is a sensory receptor that enhance the ability to bear loading. This prevents the natural tooth from the overloading. In contrast to the implants exhibit no movement or very little movement. They have a lower osteoperceptions from the alveolar bones. For this reason, the implant-protected occlusion concept is a mandatory for occlusion design in the implant restorative. The implant-protected occlusion concepts prevent the occlusal overloading in the implant by having the implant slightly under occlusions than the natural tooth, which is presented by Carl Image in 1994. Most of the time, this is accomplished by having the patient bite as a reference. The patient was instructed to bite in light bite and the natural tooth touch before the implant. When the patient bite in heavy bite or in clenching, the implant touch. In the tooth-borne situation, when you have tooth in front and the back, it's okay to have the light bite without any harm. But when you think about it, in distal end or multiple restorations implants, the tooth mesial to the implant bear loadings of the occlusion before the implant is in contact. So many studies report a vertical root fractures in adjacent tooth to the distal end implants, particularly in premolar with root canal treatments, such as Rosens and iron Rosens, also suggest that having implant lighter contact in distal end may cause overloading on the adjacent tooth near the implants. So when using the articulating papers as a marker for adjusting the restorations, the occlusal force cannot be measured because the articulating color mark side did not show the force measurement. The method used is subjective to the patient bite and the dentist's clinical experience. This makes it challenging for the dentist to adjust the optimum occlusal force to the implant restorations. One method that used to evaluate the occlusal force as a digital number are the T-scan system. This method uses the resistance in voltage and translates the percentage per each bite per time. When upper and lower teeth occlude, the resistance in the pressure is recorded as a resistance voltage and translated into data described as relative occlusal force. Each tooth has a different relative occlusal force. Each timing depends on the bite force. So this method benefits the measurement of the bite force during implant functions and can be evaluated compared to the adjacent tooth. So objective of this study is to compare the relative occlusal force between implants in the distal end and the adjacent tooth mesial to the implant biting in maximum anticipations. For the maximum method, this is cross-sectional studies. So the inclusion criteria would be the patient that had implant restoration replacing molars in the distal end space with a sitting opposing tooth with natural tooth with or without fixed prosthesis contact in the function for at least 1 year. So the group was divided into 3 groups. So this is give an example of the first group is light bite, which is light bite not touching when using shim stock, and heavy bite which touching. And the second group is touching in light bite and heavy bite. The third group is not touching at all in heavy bite or light bite using the shim stock as the measurement. So this is the example of the light bite 0 and HB1 group. So for the relative occlusal force, patient was asked to bite in maximum intercastation by clenching 3 times, and recording was made when the patient was sitting upright. The photograph for each arm was taken in the articulating color on the occlusal view to compare the photo with the force mappings. Each tooth has measurement with the width from mesial to distal marginal ridge and input the width into T-scan software. So for the measurement, we classify the occlusion type from clinical examinations, relative occlusal force of tooth adjacent to distal and implants, and relative occlusal force of distal and implants. For the statically analysis, the reliability of the T-scan was analyzed using the interclass correlation coefficients. The relative occlusal force of implant in the distal end and tooth adjacent to implant were compared using pair sample t-test. The p-value of less than 0.05 would be considered statistically significant. For the result, the demographic data, we have 20 patients with 5 male and 15 female and 45 implants. The position 38 mostly is mandible and 7 in maxilla. The duration of function is mean is 3.35 years, with 1 to 3 years is 24 implants, and 4 to 6 is 20. 79 is 1 implants. The occlusion type that divides into 3 groups, we have mostly HB1 LB0 group in 35 implants, HB1 LB1 group 2 implants, and HB0 LB0 8 implants. For the result, it is significantly in HB0 and LB0 group difference between adjacent tooth and the implants distal end. Other than that, it's not significantly different. So for the result, the null hypothesis was there was no difference in the relative occlusal force of and distal end implants and adjacent mesial to natural tooth. Within this limitation of static maximum intercuspation bite, the null hypothesis was accepted in HB1, LB1, and HB0, LB1 group, and rejected in HB0 and LB0 group. So these are the topics that we are going to talk about in discussions. The first one is maximum intercuspation positions and the relative occlusal force. In this study, the relative occlusal force of adjacent tooth and implants in HB1, LB0 group and HB1, LB1 group are not significantly different because we measure in heavy bites. So this is why it's not different. Also, we have HB1 and LB1 group, which is touch in light bite and in heavy bite. This may be because of the continuous eruptions of the opposing tooth. So it's like corresponds to the other study from Chen in 2020 when measured the relative occlusal force of the implant after inserting the final restoration. The relative occlusal force is increasingly until 3 years. So in HB0 and LB0 group, the relative occlusal force was significantly different between adjacent tooth and distal and implants. This may be because the gap between the occlusion is too far for the tooth to erupt into contact position. This might cause overloading in the tooth adjacent to the implant, and it might be because of the over-adjusting of the occlusion, which is sometimes highly polishing, and it's hard to get the correct adjusting positions. So this is the example of overloading occlusion that might cause vertical root fracture. This actually happened to in this study, the one of the premolar were fractured during the recall sessions, and it's accordingly to the study of Lee in 2016, which he also found vertical root fractures in tooth near the distal and implants. So when checking the occlusions in the multiple implants that were replacing, for example, in these patients, we have P3 and P10 patients which had implant replaced both premolar and molar. It's harder to adjust the occlusion accordingly, and we might have to check all the occlusion throughout the arch to get a well-distributed occlusion force. So it's pretty hard to get there, but it had to be done. And for the limitation of this study, there should be a more randomized control or prospective control study to clarify the effects of the occlusions and the implants and the harmful of it. And the time and the force graph can be used in further study to evaluate the complete cycle of functions and habitual contact. Also, you can use the SDL file to impose with the force mapping of the occlusions to be more correct positions of the occluded tooth. So in conclusions that derivative occlusal force of implants and adjacent tooth in the first two groups, HB1, LB1, and HB0 and LB1, there's no difference, but HB0 and LB0, which has no touch in light bite and heavy bite, there's significantly difference in relative occlusal force, and the more detail of force per timing should be investigated, and further proposed prospective or randomized control study should be conducted. So thank you for your attention. I may move on to the Q&A sessions.
Thank you very much, Dr. Chin. Thank you for your great presentation. Is there any question from the audience? This research is very valuable. Okay. May I call the implant that have the occlusal type HB0, LB0 as the non-functional implant?
Not that particularly in my opinion, because we use just only 8 to 10 micron chim stock as a reference. Mm-hmm. So, and we also use the maximum intercastation as a position that we measure. So when there is a food in between when mm-hmm. functions, it can be function also depends on the function when the mandible flex, it depends mm-hmm. on the mandible of each person how flex it is to get that into the contact.
Okay. Could you please explain more how you guide the patient to bite in the light bite force and in heavy bite force? How you guide the patient?
First patient has to we have to practice first before doing. I have to make sure that the patient bite at the same position. Mm-hmm. So usually the patient have a complete tooth with intercuspations, and then patient is asked to bite in light bite, and then I check in the tooth adjacent to the implant, make sure that tooth is in contact. Mm-hmm. That should be the reference for the light bite, and the implant is not contact. Okay, and after that, when I ask patient to bite more heavier or clenchings, the chim stock should be touched in implant and in the adjacent tooth too.
Okay, thank you. And which occlusal type will you recommend for the patient who has distal and that will balance between the natural tooth and the implants? Which type of occlusal?
In my opinion, the implant protective occlusion is already a good concept. But when you're using the chim stock and the patient statistic movement to adjust the occlusion, it might be hard for the clinician to get a good contact. So you might want to have a more reliable method that can precisely know what contact you have to adjust and well distribute. Otherwise, you have to use chim stock every tooth and create a well distribute. But But since that you still don't know how much force because it's just color, so maybe digital method would be a good idea to do that when use multiple implants treatment.
You mean that the T-scan is useful for?
Yes,
Yes.
I think it's really useful in multiple and distal and implant.
Okay, thank you very much, Dr. Chin. Your presentation is very great. I appreciate for your presentation. Thank you very much.
ขอบคุณครับ